Good morning and welcome to a brand new episode of Dr. Zen. I'm Sonia Das, your host for the day. Today we have with us a consultant IVF specialist with over 16 years of dedicated clinical experience in IVF and obstetrics. He has a special interest in gynecological endoscopic surgeries, including advanced hysteroscopic surgeries. He is also specialized in the management of high-risk obstetric cases. He was the assistant professor at Faculty of Medicine at Ain Shams University, Egypt, and was also the consultant at Faqih IVF Center. He was at the role of medical director with Eve Fertility Center and also Amal Ilyas Fertility Center. And at present, he is the medical director at Summer Fertilization Center. Let's welcome to today's episode Dr. Ahmed El-Bohoty. Welcome, doctor.
Thank you for your nice introduction. You're welcome.
Great, doctor. So as a career as a consultant IVF specialist with over 16 years of vast experience working at many acclaimed hospitals and clinics, how is Summer Fertilization Center different from other organizations?
Actually, IVF is very growing in its technology and in its outcome. There are a lot of interventions every day. Some are useful for some patients. My strategy in Summer Fertility Center is to put patient at the first priority when we add any technology, any intervention to improve their outcome. Generally, there are a lot of interventions, as I'm telling you, there are growing interventions, but actually not all patients need it. So we need to be patient-centered care,
Right.
not business-centered care.
Right.
And this is what I'm trying to implement in Summer Fertility Center.
Right.
So my patient is the first priority. We need to individualize the care, to put them what they need. They need genetic testing, we will add. They don't need, we will not add.
Right.
And make the procedure simple as much as we can, with less cost as much as we can also.
Great, doctor. It was told that you have a special interest in gynecological endoscopic surgeries, including the advanced hysteroscopic surgeries. Could you elaborate on that for our viewers?
Yes, in gynecological endoscopic surgeries are very big specialty. It includes a lot of work for many things, for oncology, for urogynecology. I am so interested in part related to fertility.
Right.
And this gives me, as a doctor, a chance to give patients alternatives. Sometimes the endoscopic surgery may work rather than having IVF. Sometimes we need to prepare patient before having IVF by having like hysteroscopy. Sometimes there is a condition like submucous myoma. It's like a small tumor inside the cavity of the womb. If we do IVF, the patient cannot be pregnant.
Right.
So we need to individualize also the care. When we have a problem, we need to solve it for patients before having IVF. And sometimes there is some delay of conception related to some problems that can be solved without having IVF. Okay. So it gives me the chance to increase the chances of pregnancy, whether with IVF or without IVF.
Right. So what exactly is the hysteroscopic surgery? Sorry.
Yes, no problem at all. Hysteroscopic surgery is a type of endoscopic surgery. It's a very small telescope or camera that can be introduced inside the womb. Okay. It gives us a chance to diagnose what's inside the womb, and also if we have something abnormal inside the cavity, we can treat it.
Okay. So do you usually do that first and then go for the IVF?
No, not usual. It's only for specific cases.
Right.
And this is the most important that I am focusing on, that individualizing care is the most important thing in treating infertile couples.
Right. Do you prefer fresh or frozen embryo transfers, and why?
I prefer both.
Okay.
Both are good. As I'm telling you, it's individualized care, but generally my aim for having IVF is to make a fresh transfer in addition to freeze surplus embryos. Right. So this is my aim. It may not be successful in all patients to have surplus embryos.
Yeah.
So we may end only with fresh transfer. But in case that we have surplus embryos, and this is my aim from the start, we will have it as a backup. And sometimes the patient can be used after having a pregnancy. Some patients can have 2 or 3 pregnancies from one stimulation cycle.
Right.
However, there are indications for freeze-all, that we do freeze-all embryos without having a fresh transfer. Like for couples who are indicated to have genetic testing, we need to freeze all embryos, and because we will take the biopsy at day 5, and we will freeze then the embryos till we know the results of these embryos, that they are healthy and normal, and then transfer in another cycle.
Right.
Sometimes we have some cases of hyper responders that it's more useful for them to be postponed their transfer to another cycle. So there are some indications.
But as you said, it may not be successful in all couples, right? If you use the frozen embryos.
No, I am not telling it's not successful. It should be has the same success rate for the transfer for the same embryos quality.
Right.
So if the freezing protocol is good and thawing protocol is good, we need to end with a good results from the frozen transfer.
Right.
That is not different than the fresh transfer.
Okay.
However, I don't like to make it as a policy for all people to postpone their fresh transfer.
Right.
Because with fresh transfer, we will end with lower cost. We can have a pregnancy in a shorter time.
Right. Okay. So, what is the message that you would like to give to our viewers on IVF treatment?
As I'm telling you, IVF is addition to life, not only to medicine. It makes a lot of changes in social relationship, in number of population, in a lot of things, and it's continuously adding, and it gives a chance also for solving problems not only related to fertility. It solves problems related to abnormal genetics, families with genetic disorders and hereditary disorders that cannot be solved without IVF. But we need to know that and to focus with our patients that it may not be successful from the first time. It may take some time. There is a chance of success for each couple. It's not a magic. We cannot make all people, all couples pregnant from the first time. And we are a lot that we don't know about why still there will be some couples we cannot make them from the first time pregnant.
Right.
So it needs some patience from the patient. And to know that it's Allah willing at the end. We cannot do magic, but there is hope. There is always hope, even with the most difficult cases.
Right. So can you give us a short insight into the comparison between fresh or frozen embryo and hysteroscopy or no hysteroscopy?
I think we talked about the fresh and the frozen embryos, but I can tell you again in a simple words that with stimulation to get more eggs, we fertilize these eggs and we have embryos. We can transfer these embryos in the same cycle of stimulation, so it's fresh embryo transfer.
Right.
Sometimes we cannot transfer more than 2 embryos. And usually we transfer 1 or 2.
Right.
And if we have a good embryos, more than 2 embryos, we need to freeze them.
So is that the reason why there are multiple, there are chances for twins and
triplets? If we transfer more than 1 embryo, we increase the chance of having twins. So that's why now we are transferring 1 embryo for women who have a high chance to get pregnant, like women under 30 years. If they have lesser chance, we can transfer 2. But very rarely we will go to transfer more than 2. And it shouldn't be done except in very rare conditions. Surplus embryo, if we transfer 1 and we have another one, we need, in a good quality, we need to transfer to freeze it, which is freezing surplus embryos. And this gives a chance to have another cycle later on, maybe after 1 year, 2 years, with the same success rate of the age that we took eggs at this age, because women are going to have less chance with age. This is for the fresh transfer. For frozen embryo, we can have surplus frozen embryos, or we can have from the start the policy of freeze all embryos. As I told you before, in some cases, we can aim from the start to freeze all embryos, especially if we will do a genetic testing of the baby or the woman, or to protect the woman from having a condition called ovarian hyperstimulation syndrome, which you can protect it easily by canceling the fresh transfer.
Okay.
In my opinion, we need to have indications for freeze all policy, not to make it as the rule for all women who are undergoing IVF treatment.
Right. So if one woman or one couple undergo the IVF and they are successful and they got a baby, so later on for the next try, again, can they opt for IVF or no? Or should they actually try the natural way of conceiving?
According to the indication of having IVF, if this is permanent indication and it will not be resolved, they will go for IVF again. If it's temporary indication, or for some cases it's unexplained reason, and in these cases if they have like 2 years, we need to advise them 2 years delay, we need to advise them to go for IVF. Sometimes after having IVF and having the child, they may have a chance to get pregnant. But if there is a clear indication that both tubes of the female are closed, or there is a problem in the male, so we need to advise them to have another IVF.
Right. So, doctor, you had spoken about the genetic testing as well. So, if there is, God forbid, a genetic disorder in the family running, so how does IVF prevent that being carried on to the next?
By selecting embryos, by taking cells from these embryos and send them to the genetic lab to identify the good and healthy embryos from the genetic lab.
Right, but would that be 100% like surety that it would not be carried out for sure?
Yes, for genetic testing, if they tell us this embryo is free from this genetic disease, from this particular genetic disease, yes, it will be free of this particular genetic disease. But there are a lot of things that we will not test, like having congenital anomalies. It can be not related to genetics, or what we already tested. But for the particular disease, if we are, for example, for thalassemia disease, if the couples are carrying thalassemia gene, and we are testing embryos that they are free of thalassemia, and we select that embryo free of thalassemia, and the patient is pregnant, yes, her offspring will be without thalassemia.
Oh, that's good.
We didn't complete hysteroscopy.
Hysteroscopy, yes.
Yes. Hysteroscopy is a nice procedure to identify what's inside the womb and how the lining is. But it's not a routine procedure. It is not done before each IVF cycle. Only if we suspect a lesion, or there is, after multiple recurrent implantation or not having a pregnancy with repeated IVF trials, with transfer of a good embryo, we can think about it. But we will not do for all patients. It will not add any success for our procedure if we used it as a routine.
Right. So, doctor, technology is defining everything today. And how is it changing the way assistive reproductive technology, ART, is done these days?
There is a lot of changes from the start of IVF in 1978 till now, actually. It started different procedures. I will not go for the history, but I will go for the recent technology. Actually, now we have genetic testing is a part of the recent technology, and the technique of genetic testing is also developing more and more. I told you the standard now is to take cells from the embryo, which can actually be little bit harmful for some embryos to take cells from it. Now we are going to take like a fluid from the culture media around this embryo.
Oh.
So it becomes less invasive procedure. But it's not the standard technique, but it will go one day to be less invasive to harm embryos by any means, and it will be more easy.
Right.
We have also progress in the incubators for the embryos. We are now on the era of time-lapse, which have a camera inside the incubators to follow up the embryos minute or second by second, and to know the best embryo in dividing. And also it's very interesting to follow how the embryo is growing, and to give for the couple after transfer of the embryo how is a short video about the 5 days of this embryo inside the time lapse.
Okay.
So it's very interesting for doctors and also for the patients. We have many things that trying to improve from the culture media, from the technologies in under process. It needs a long of time to speak about.
All right, doctor. So, Dr. El-Bohoty, before we wind up, one last question. A couple who has been trying, if they failed twice in IVF, do you think that they should try one more time? Or do you think it will be successful? Is there any chance?
First of all, there is always hope. And sometimes this failure maybe is by chance,
Right.
bad luck. But we will not depend on this and tell them just repeat. We need to study what has happened in the previous 2 cycles.
Right.
Start from how they were prepared for that. We need to check the stimulation protocol, the medications they are taking, the number of eggs, the quality of eggs, the number of embryos formed, the day of transfer. Everything in the previous cycles we need to study, and to implement the new technologies in these cases, which will not use it as a routine in other cases.
Right.
Sometimes we need to test these embryos genetically, if these are genetically normal, chromosomally normal, or not, because the most common of not having a pregnancy after transfer of a good quality embryo is to have a chromosomal problem in the embryos.
Oh.
Sometimes there may be a problem in the lining of the womb. So this is a good example. If there is a problem, they can be solved by hysteroscopy. If there is any suspicion, by the scan. Sometimes there is discoordination between the lining or the day of lining, because the lining has like a days that should be compatible with the days of age of the embryos.
Right.
So there is a new test also called the ERA test, endometrial receptivity test, that is not a routine test, but it can be helpful for like these cases.
Right.
So we need also to see it's useful for this case or not, because all of these will not be generalized to be used even with cases of repeated failure. We need to individualize. This is the job of the IVF consultant, to select what's useful and how can we encourage them to do another trial with a higher success rate. And I found there was a lot of challenging cases. I had one case after 6 times of IVF failures. I followed what I told you for you. I brought all the files for her from previous centers. I studied them. I checked what can I improve. Even if it's doing good things, we can sometimes improve or add. And at the end, she was pregnant and have live birth.
Right.
So, also the couple should be optimistic, not to lose the hope, because there is always hope, inshallah.
Right. So is there a particular number of times that you can try IVF or no?
The limitation of time is if there is a problem of producing eggs or sperms.
Right.
If there is no problems, if the patient can produce, if the woman can produce eggs and the husband has sperms, there is always hope. If no, we cannot have if there is depletion of eggs or there is no sperms at all, whether with normal production or by biopsy from the testis. So we need to stop at this point.
So with this, we have come to the end of the interview. Thank you so much for your time, Dr. El-Bohoty. And it was a pleasure having you with us.
Me too. Thank you.
Hope you enjoyed.
Yes, sure.